Hi everyone, welcome to part 2 of this topic on pharmacodynamics. In this part of the topic, we're going to talk about drug desensitization to begin with, and then individual responses to drugs. So there are only 2 learning objectives for this recording, so let's get stuck into it. So firstly, be able to define the terms desensitization, tachyphylaxis, tolerance and refractoriness, and explain how they are different from each other. So often the effect of a drug gradually diminishes when it is given continuously or repeatedly, and this is referred to as desensitization. And I'm sure that it has happened to some of you when you're taking a particular dose of a drug for a period of time, and you start to notice over time that the effect of it is kind of wearing off. So you might go to your GP at this stage, and they might, suggest a couple of things to do. Firstly, they might suggest to increase the dose. Now, sometimes that works, but sometimes it doesn't, and the desensitization has already set in. In that case, they might suggest the changing of the timing of the doses. So you're on the drug for a period of time and then off, and then on, and then off. And so this works to prevent desensitization occurring for some classes of drugs. For some people who have that chest pain, so angina from blocked coronary arteries, so that ischemia that is caused from that, they take a medication in a tab that they put under their tongue. And so changing the timing of that seems to help with that desensitization for some people. And then if those things don't work, then the clinician might, suggest a change to a different class of drug altogether. Often, though, this desensitization develops in the course of a few minutes. And in this case, it's called tachyphylaxis. Now, some of you may know that the prefix tachy refers to kind of abnormally rapid. You might have heard of it in terms of tachycardia, in terms of abnormally rapid heartbeat. And phylaxis is from Greek, and it's sort of roughly translated as protection. So what we're seeing here is rapid protection by the body to a particular dose of a particular drug. Now, in terms of different drug classes that tachyphylaxis occurs to, it does include the amphetamines, and also for people who like to eat magic mushrooms, and the psilocybin being the active ingredient of the active mushrooms is the one that's generating this tachyphylaxis. I'm not sure if any of you are fans of Bridget Jones' Diary movies, but I think this was number 2, where she had a magic mushroom and ended up face planting in the sand. But enough of that, we'll move on. Now, tolerance then is a more gradual decrease in the responsiveness to a drug, and it takes days or weeks to develop. Now, the words tolerance and dependency and addiction are often used like interchangeably, but they are different, right? So the tolerance part is that gradual decrease in responsiveness to a drug, and that can lead to dependency. And as its name suggests, you become dependent on that particular drug. And if you stop taking it, you might have withdrawal symptoms, and that might be just something mild like a headache or nausea, or they can be very serious and things like psychosis if you just stop taking something that you've become dependent on. And then, of course, dependency can result in addiction or substance abuse disorder, whereas there's that, consistent urge to take a drug, even though the person knows that it has either caused harm or will cause harm or has the potential to cause harm. All of these terms, desensitization, tachyphylaxis, and tolerance, will result in refractoriness, which is the loss of the therapeutic efficacy of that particular drug. And we have a particular type then, another type of drug resistance, where there is the loss of the effectiveness of antimicrobials or anti-tumor drugs. So in terms of antibiotic resistance, you've got to remember, that microbes are bacteria, are those single celled microorganisms that replicate very, very quickly. And every time they replicate their DNA. And, that can over time induce or introduce a mutation that confers antibiotic resistance. Anti-tumor drugs as well. There is a type of drug resistance here as well, and this is often due to the presence of these exchange pumps in the plasma membrane. So with people who develop this resistance, the drugs are kind of pumped into the cancerous cells, but those exchange pumps act to pump the drug back out again before it has time to act, and that's obviously a type of drug resistance. Bye-bye, Bridget. Now, there are many mechanisms that do lead to desensitization or tachyphylaxis, and we are going to describe these over the next few slides. So they include a change in the receptor or a translocation or movement of the receptors, exhaustion of mediators, increased metabolic degradation of the drug, possibly due to induction of hepatic drug metabolizing enzymes, active extrusion of drug from cells, so that cancer chemotherapy that I just mentioned, and finally physiological adaptation can occur. So if we start with this first one, which was a change in receptors, a conformational change, so a shape change, can occur in the receptor, which inhibits the efficacy of the drug. So the agonist drug can bind to the receptor, but in this situation, it can no longer activate it. So for example, phosphorylation can sometimes occur of the receptors, which stops them from efficiently activating downstream effectors. So that's probably a little bit wordy to understand. So I've just made this little schematic here. We have our plasma membrane. We'll plop in this transmembrane protein, obviously with the receptor with binding sites there. I've also put this little star here to kind of indicate, and if you've been watching the videos on the Brightspace site, you'll see that when the agonist normally binds to the receptor, it activates it, and I've denoted that by the lighting up and spinning of that star, right? But what can happen in this case is phosphates can bind here and here, and that kind of changes the shape of the receptor itself so that it doesn't become activated, right? So the agonist drug itself can still bind, but we don't get activation. Now, what happens is when the receptor is activated, you get this series of downstream reactions that occur, and you get activation of downstream effectors. But in this case, because the receptor is not activated, you don't get activation of those downstream effectors, which might be enzymes such as protein kinase or phospholipase. And that's what you're looking for here. You're looking at here. So the agonist can bind, no activation, therefore no activation of these downstream effectors. Therefore, there's going to be no cellular response to that agonist drug that bound to the receptor. And this is the desensitization with loss of the drug efficacy. The second mechanism then is translocation of receptors. Now, the word translocation means the movement of something from one place to another. So here we're talking about the movement of receptors and the movement of receptors inside a cell. So receptors are internalized such that the availability of the receptors is decreased. So this is called translocation. It's also called downregulation of receptors. Now, in certain situations, which we'll learn about as we go through this subject, receptors are downregulated when they're, chronically exposed to high levels of something. So for type 2 diabetes, really high levels of insulin in the bloodstream causes the insulin receptors to be downregulated. And we'll learn that, type 2 diabetes is predominantly a condition involving insulin resistance. Sometimes receptors are upregulated as well. Now, if we look at this here, somebody who is exposed to a drug called isoprenaline, which is, mimicking the effects of adrenaline by binding to the beta-adrenergic receptor, this can occur with this translocation of receptor. So if we look here, normally speaking, I've just got the plasma membrane, those 3 transmembrane proteins. We've got the 3 agonist drug molecules. They normally bind, and that's it. On exposure to particular drugs where this desensitization occurs, I've done this to the best of my ability, what you see is internalization of one receptor. Those 2 other agonist drug molecules can still bind, but there's nothing for this one to bind to. And that's where you see that sort of loss of, efficacy of the drug, because there's fewer receptors for it to bind to. Third one is exhaustion of mediators. This means there's a depletion of substance required for a drug response. And we do see this with amphetamine use. What do amphetamines do? They cause the release of amines from neurons. Once all of those amines have been used up, these drugs are going to have decreased potency, and it's going to take time for those amine stores to build up so that initial dose of amphetamine has the same effect. Number 4 then is increased metabolic degradation of the drug. So the body produces more enzymes that catalyze the chemical degradation of the drug. And this is usually because of induction of the hepatic drug metabolizing enzymes. So hepatic meaning the liver. So the liver enzymes, the number of them increases. And where do we see this? You might see it in a person who is consuming alcohol, the same amount of alcohol day by day, on a day-by-day basis. And over time, then there will be a lower plasma alcohol level because of the induction of these liver enzymes to metabolize that alcohol. There are also examples, though, where there is a decrease in enzymes required to metabolize a prodrug to produce an active drug. Now, a prodrug is an inactive drug. It's sometimes administered because in its inactive form, it's better absorbed, and then the drug molecules go to the liver, where those hepatic or liver enzymes then metabolize it to produce the active drug. So if you have a situation where there's a decrease in enzymes to make the drug active, therefore the more drug that's in the inactive form is going to be useless, and that's a form of desensitization. Now, I have spoken about this number 5 before, the active extrusion of drug from cells, which we see when resistance develops with cancer chemotherapy. Here we have our anti-cancer drug, which needs to enter a target cell to have an effect, but the target cell here is expelling the drug too quickly, and a lower intracellular concentration of the drug will occur, therefore decreasing its potency, and then that's leading to that resistance. And the last one then, number 6, is physiological adaptation. So there's a readjustment of homeostatic mechanisms which often occurs to compensate for the drug action, right? So there are a class of diuretics called the thiazide diuretics. Now, remember what diuretics do. They increase urine volume, and by increasing the output of urine, that's going to decrease blood volume and therefore decrease blood pressure. So these diuretics are given to treat hypertension, right? Now, thiazide diuretics increase the production of urine, as I mentioned, to decrease blood volume and blood pressure. But in some people, that decrease in blood pressure activates the renin-angiotensin II system. Now, you should be familiar with that from previous physiology subjects. So remember, renin-angiotensin II aldosterone system is stimulated when blood pressure drops, right? So here, the use of the thiazide diuretic causing the decrease in blood pressure in some people is registered then as, an abnormal drop in blood pressure, and this renin-angiotensin 2 system then is stimulated, which increases the blood pressure again. So you can see that the effect of the thiazide diuretic and the activation of the renin-angiotensin 2 system is cancelling each other out, and blood pressure is going to remain high. And so, this is why, it's classified as a form of desensitization. And physiological adaptation often occurs more gradually, resulting in tolerance. And mostly when this does happen, a clinician will prescribe a different class of drug to treat the hypertension. Okay, everyone, I'm going to stop here. And when I come back, I'm going to be talking about individual responses to drugs.